Good afternoon, and thank you for this kind invitation. I have the impression to repeat always the same thing, so I hope that I will not be too boring. I was asked why, when, how. Why treating concomitant TR? This is obviously the major question. Why should you do it? I think that there are two ways of seeing the problem. Is whether you want to treat only severe TR, you'll treat less than 10% of the patients. And this is what many people still do. Or you believe that less than severe TR, and then you need to define what is less than severe TR is precisely, and you need to consider perhaps other parameters than tricuspid regurgitation. We did show in a paper in 2005 that there was some influence of the tricuspid annulus on the tricuspid regurgitation, and not only that, but that untreated tricuspid valve would trigger an increase in the grading and in the rate of tricuspid regurgitation with time. So we had shown that a remodeling annuloplasty of the tricuspid valve based upon tricuspid annular dilatation size would improve functional status, irrespective of the grading of the regurgitation. And we showed also that you could have a tricuspid annular dilatation that could be present, irrespective of the grading of TR. And that dilatation, as I said, is an ongoing process. I showed this diagram from this talk because it is probably the key of it, is that in the group, because we compared two groups of patients, for those who haven't read this article, is that we compared a group where we treated patients only with mitral repair, and we treated a group where we added a tricuspid annuloplasty. And basically, we showed the incidence of TR grading in both groups after 5 years follow-up. And we shown that there was an incidence of tricuspid regurgitation 3 and 4 plus, which came from none at initial, at the beginning of the study, and reached 30% at 5 years follow-up, mean follow-up. So this was where we concluded that this was a self-perpetuated process. Funny enough, there is a paper from the Mayo Clinic, which was published a few years ago, where they said, well, you mustn't be concerned about this process because there is no ongoing process. Now, if you look at this paper, which is quite interesting, their population is referring to 109 patients. Initially, this study includes 696 patients. I don't know whether 700 or 600 that our remainders have gone. But I mean, however, they deal with 109 patients they have been following for 5 years. And they have separated TR 1 plus, 2 plus, and 3 plus, 4 plus. And what they find is that at the beginning of the study, they had 13% of their patients who had 3, 4 plus TR. And at 5 years, they had 29%. So they had exactly the same incidence that the one we found. But very surprisingly, they said, well, this is not a problem, and this is not an ongoing issue, and there is no progression of TR, and you should not put an annuloplasty ring to patients who have some degree of TR. Okay, so this is all about medicine, basically. We see the same things, but we don't analyze it the same way, and we don't draw the same conclusions. So, and this you can see is, I'm sorry for the quality, but only those who are close to it. This is what they show, this very tiny grade 3 plus or more, 32, which is 29.4%. This is the diagram in their publication. Now, this concept of treating moderate TR, and that we're going to come to that just after, was approved by the Cleveland Clinic, who said that, basically, if you had a tricuspid regurgitation that was moderate, you should rather treat it. And also they included female sex and valve replacement as opposed to valve repair. I think there are a lot of parameters that have not been studied. This was also showed by this conclusion, and it was shown by a prospective randomized trial from Rome. They didn't include many patients, but it was very well designed study, and they really showed that patients who were not treated with a tricuspid annuloplasty had a much worse outcome than those who had a tricuspid annuloplasty. This was confirmed by Steve Bowling, who was also advocates to treat tricuspid regurgitation, was confirmed by a Greek publication, and was even confirmed by a friend of mine who's present in the audience today, Frank Wells, and who basically said, well, you know, in the beginning of this publication, it seems that I thought that he was going to say that you shouldn't treat patients unless they have severe TR. But if you look at this diagram, basically he said, well, functional TR, severe, be treated, but moderate, well, basically consider annular dilatation, and then probably has to be treated. And so it is something which remains complicated. And it's going to get even more complicated when you want to say when. Because if you look at publications from cardiologists about the grading of functional TR, there is still a big remaining issue. This paper was signed by Sarano and Badano. Badano works in Italy, Sarano, as you know, the Mayo Clinic, and these are really high-flying echocardiographers and cardiologists. Now, they say in their table that basically functional TR, unless you use any method, qualitative, semi-quantitative, or quantitative approach, there is no definition of what is a moderate or mild TR. They can define severe, they can define none, but in the middle, it's a complete gray zone. So, and I've never seen, given this talk, unfortunately, too many times for the audience, but I've never seen a cardiologist raising his hand and said, no, no, this is what you're saying is not true. So, basically, we find ourselves with the quantitative approach, which is the reference, saying we know what severe TR is, but we can't define moderate TR. So the new modern approach of tricuspid regurgitation is to say, basically, we know what is none, we know what is severe, and in the middle, we don't know. So when people say I treat or I don't treat moderate TR, I don't understand clearly what they want to talk about and what they're doing. Because you know, of course, that so moderate TR has no precise value, assessment method is not accurate and reliable, and so therefore relying just upon grading to decide surgical intervention seems to be wrong. And this paper, funny enough, although it's 3-4 years ago, says, what is moderate TR? And they say, well, if you have mitral surgery, you have severe tricuspid regurgitation, of course you have tricuspid valve surgery, but if you do not have tricuspid, severe tricuspid, you have to consider annular dilatation and moderate tricuspid regurgitation. They have defined themselves 1 or 2 pages before that they did not know how to grade moderate TR. It's a bit surprising. I barred hypertension, pulmonary hypertension. Why is that so? Because I've never found in all of my studies that pulmonary hypertension had a role. I think we're talking about left ventricular dysfunction. Pulmonary hypertension is not the real disease. It's a surrogate of a left ventricular dysfunction. Either you have residual MR or you have LV dysfunction. But pulmonary hypertension is not a marker to trigger a tricuspid regurgitation. And if I want to give you an example, Eisenmenger's disease do have suprasystemic pulmonary pressures and rarely develop tricuspid regurgitation. So tricuspid regurgitation cannot be developed only by pulmonary hypertension. I think this is also written everywhere, and it's a wrong statement. So grading is not reliable, and we know why grading is not reliable, because it varies according to many parameters, which is preload, afterload, right ventricular function. We all have seen patients coming in with 4+ TR, give them IV Lasix for 3-4 days, re-echo them, they have no more TR. They are the same patients. There's the same patients, just with less preload and probably a better afterload. So it is really an issue, and we don't really know what to do with these patients. Now, 3D has been said to be beneficial. yes, it is true, you can acquire the entire valve, you see the real size of the annulus, you can measure the tenting volume, you can quantify the anti-leaflet surface and assess the right ventricular modeling, but you need a sinus rhythm because you need 4 cycles. The quality of the imaging remains an issue. If the valve is thickened like the Barlow's of the right side, which are very frequent with myxomatous valves on the left side, you have the same disease on the right side. It's difficult. Learning curve is long and the acquisition is long. And you see that if you compare a 2D echo with a transgastric view, where you see the anterior leaflet, the septal leaflet, and the posterior leaflet, and you look at the 3D echo, you don't have much more information with the 3D echo than you would have with a good 2D transgastric view. So we are left now with this famous parameter which has been criticized. Okay, 17 intraoperatively was a surgical assessment. 40 millimeter by transthoracic echocardiography has been included into the guidelines of ACC/AHA and ASC as a 2A criteria, whether it's, of course, it's not evidence-based medicine, but it shows that there is a trend that people do have to consider the tricuspid annular dilatation is something. So we wrote this editorial last year in JACC about what we should do with this damn, I would say, functional tricuspid regurgitation. Should we leave it alone? Should we consider it? Should we treat it or not treat it? I think we came with this proposal of a new assessment of the tricuspid valve, which does not rely solely on grading or solely on annular dilatation. I think it's a mistake. So basically, the grading is no TR, mild TR, we all agree. In the middle, let's call it moderate TR because we don't know what it is. Everything in the middle. And severe TR, we know what it is and we can quantify it. Leaflet coaptation mode, I think it's crucial, especially in functional disease. It's true for the mitral, it's true for the tricuspid. If you have a coaptation that takes place at the annular level, whether surface to surface or edge to edge, it's not the same disease. Whether you have it below the annular plane and whether it's surface versus edge to edge or tethering, if you have a true tethering, it's an entity on its own. It doesn't, you don't need to have an annular dilatation which is bigger than 40 to have a tethering, and it does happen much more frequently in patients with rheumatic heart disease than it does happen with degenerative heart disease. However, we have seen some tethering in some degenerative heart disease. And then, of course, the annular dilatation below or above 40. So now you shake that all and you have 4 stages, you have 3 stages. You're left with 3 stages. Stage 1, why on earth would you do anything? This is more than 50% of the patient. They have an annulus which is below 14, they have 40. They have a coaptation which is surface to surface at the level of the annulus, and basically you don't need to do anything. Now, stage 2 and stage 3 are very different. So, sorry. So this is a patient that I showed you before. This is a patient where already you have an annulus with 40 and you see a trace of TR. And I think that this is a patient which has 42 millimeters, no trace of TR. And, well, basically we believe that these patients should be treated. So how? They should be treated most likely with annuloplasty ring, and I need, for the sake of time, to go a bit faster. And basically, semi-rigid rings are important. First of all, because they allow to remodel the annulus, and this concept which was brought up by Carpentier is true for the tricuspid as it is for the mitral. And also, it allows you to go for a valve in ring in the future if it fails, because now the tricuspid valve is probably the most approachable valve through percutaneous techniques. So this regurgitation should be treated. And this one, which is the tethering, is a third concept, which is, as you see, is a coaptation point which is well below the plane of the annulus, about 1 centimeter, and you have a torrential TR usually all the time. The valve remains open in systole and diastole. You have this form of tricuspid regurgitation. We described this technique because we couldn't find a way to achieve the coaptation inside the right ventricle as opposed to at the annular level, which is a patch to increase the size of the right ventricle. I need to go a bit fast, so I'm going here on the screen if I can find the. No, I can't find it. I'm sorry, but if someone wants to see it, I can show it afterwards. So the impact of concomitant tricuspid annuloplasty has been shown by David Adams on the 600 patients, and which has brought up a tremendous discussion and arguments with Tyron David, who said that this was not true and there was no need for tricuspid annuloplasty. And we have had this reply from Robert Dion saying that he thought that the air was different in Toronto than it was in London, in Rochester, in New York, or in Milano. And basically, there was no reply by Tyron David. And last year at the AATS, I got the privilege, if not the discomfort, to be the discussant of Tyron David in his paper, where he said that in a cohort of 1,172 patients, which he had followed for 25 years, I mean, this is really something that is already extraordinary, there was no progression of TR. So we had a big discussion on this point. And I think we have to have another discussion this year at the AATS, but I can't disclose that. Okay, so I thank you very much for your attention.